Thank you very much for joining us, and welcome to the Symposium, part of the Cancer Care Day, an event jointly organized by Siemens Healthineers and Bayer. My name is Elisa Roccia. I'm the Global Clinical Marketing Manager for MR Oncology at Siemens Healthineers, and it's a great pleasure to moderate this session today. So the goal of this symposium is to discuss the latest advancement and the latest developments in prostate MRI together with 4 experts, which I will introduce during the session. And this is indeed the topic of our second expert, Professor Anwar Padani. Professor Padani is oncological radiologist at Mount Vernon Cancer Centre in London and Professor of Cancer Imaging at the Institute of Cancer Research. He's a trustee of the International Cancer Imaging Society and co-chair of the International Prostate PI-RADS Committee. Professor Padani, welcome on stage.
Good afternoon, everybody. So I'm very grateful to Yuri for pointing out there's a typo in my title slide. Thank you, Yuri. You see, he's got really sharp eyes. So these are the Siemens disclosures, and these are my disclosures. So Siemens Healthineers, and that's why I'm standing here today. So Francesco has just emphasized the importance of quality, not only for diagnosis, but also for staging and restaging, as you all know. And Francesco also talked about the challenges that we have. And this basically is a result of a small organ deep in the pelvis, surrounded by air and metal. And this causes us lots of problems. There are mitigations, as we've just heard, but all these mitigations that you've heard about are all have limitations. So this is where deep learning reconstruction comes in. So deep learning reconstructions essentially take undersample case space, use a convolutional neural network to yield high quality images, which you can see. Okay, so in other words, they completely ignore all these other steps. So this inverse Fourier transforms that we used to do in the past, gone. Yep. The ability to take undersample case space to make it higher sample case space and then inversely Fourier transform, gone. Okay, so we're basically mapping low quality undersample case space directly to a high quality image. So that's the basic idea. And so you can not only reconstruct using CNNs, this undersample case space, but you can also use the same technology in a slightly different way, obviously, to increase sharpness and improve contrast. So you can get CNR and SNR improvements. Now, and here you can see very nicely what the impacts are. So the impacts are a reduction in time, so 256 seconds on the top left, 46 seconds. Okay, same patient, same day, one sequence followed by the other. Okay, so this is the improvement in the quality in this particular instance in terms of the motion, but in less time. Okay, and if you look at that coronal reconstruction, you'll see the sharpness of the capsule and the ability to see the lesion much better on the deep learning reconstruction image. And you will see that you can get all of these advantages across the entire spectrum. I haven't used DLR in this particular instance for diffusion imaging. So you get improvements in sharpness, improvements in motion correction, and improvements in time. Okay, so how much time do you save? On average, it's about a third. On average, it's about a third. But you can then add on to that the other methods that we already use to accelerate images, such as compressed sensing. And if you do that, you can get a 50% reduction. But you could even push it even further. So, you'll see radiologists, my radiologist, saying gives better images, and it does. And less motion artifact, as I've just shown you an example. Okay, so these are the quality improvements, and you'll see similar quality improvements in DWI also, because this is completely agnostic. So better signal to noise, better lesion conspicuity, and better fidelity of the ADC maps. And in general, the literature shows that you get between a 20 and a 50% improvement in acquisition times. Although I have to say, I'm not realizing that because I think I'm quite fussy about the quality of my DWIs. The nice thing is those low quality, ultra high B values that we struggle with at 1.5, it's possible to obtain those because you can play with either spatial resolution or sharpness, but also contrast. So you can play in different ways. Okay, so here's an example of deep learning reconstruction applied to DWI. And you can see on the bottom row, the DLR is shown, and it's equivalent in terms of quality, I think, but look at the time difference. It's about 50% less. Okay, so the important thing from my perspective is not just the visual image, but also the ADC. What happens to the ADC? That's an important question. Well, they are not the same. There are variations, okay? But these variations, in fact, it turns out, is less than the test-retest reproducibility of these sequences. So some of you will have seen the Kiba protocol that was published late last year. And the differences you see in ADC is actually within those differences. The other thing is, if you do linear correlations, I don't like linear correlations, but there's a very strong linear correlation between ADCs with and without DLR. Okay, so the important thing from my perspective is that the differences in ADC values between peripheral zone and transition zone, or between central zone and transition zone, etc., are preserved, and that's important. And the clinical impact of these small ADC changes, in fact, is probably not clinically relevant. Now, this is an AI technique. With any AI technique, you're going to get hallucinations. Do we see hallucinations? The answer is yes, you do. And that's because things that we don't normally see because it's hidden in the noise suddenly becomes more obvious. Similarly, depending on how you set it up, you may lose lesions adjacent to the capsule if there's too much smoothing. And I just wanted to show you an example. So look at this DLR image. There's a transition zone nodule anteriorly on the left, and you'll see with a higher DLR, this is now beginning to look like a charcoal sign. Yeah, need to be a little bit careful. So this is another DLR, again low, without DLR, low, medium, and high. And if you look at the ischiorectal fossa, you can see the improvement in the noise. But look at the arrow. The arrow points to this string of glands which become more obvious compared to the DLR, to the images without the DLR. So you reduce the noise, and suddenly you're beginning to see structures that you weren't seeing before. So the real question is, what is the impact on AI software? Okay, and if you look on the top right-hand side, you can see the lesion of level suspicion does in fact change quite subtly, right? 79, 73, 76. So the same software, the same ADC, but I've just changed the T2s and the setting on the T2s. So there are very subtle differences, okay? Now, this, in my experience, it has a fairly neutral impact on the patient. So here's an example of a negative impact due to DLR. So if you look on the left-hand side, you'll see with conventional T2, you've got 3 false positives in the transition zone. With DLR on the bottom right-hand side, you have 5. Okay, so a negative impact, more false positives in this particular instance. This is a positive impact of the DLR. Top left, conventional T2, the AI does not pick up this peripheral zone lesion. With DLR, the AI picks up the lesion. Okay, so there may be some variability, but most of the time I notice that the impact is neutral in terms of its impact on deep learning reconstruction, deep learning AI. So we need to somehow mitigate that. So one of the things you can do is use retrain the AI using deep learning reconstructed images. That would be one way of doing it. Another way to do it is to set more conservative settings, and that's the way I've tried to do it. But the important thing is you need to be involved and looking at these images, so the human in the loop continues to be important. But I guess the major thing is, does it make a decision? Does it make a different biopsy decision? And in fact, if you look at biopsy decisions, what you notice is if you look at PI-RADS scores and look at the literature, it suggests that, in fact, the PI-RADS agreements are, in fact, slightly better using deep learning reconstruction, and confidence levels about what a PI-RADS score is, in fact, higher using deep learning reconstruction. And that's not surprising because you've got better quality images. There's only been one prospective study. And that prospective study showed that there are changes in the PI-RADS categorization in about 6% of patients. Okay, so it could have an impact on decisions to biopsy, right? Has that been well documented? No. That still needs to be looked at. So we need further research about how these DLRs will alter our decisions regarding the need for a biopsy. But at the moment, there doesn't seem to be a strong literature either way that it alters decision in a harmful way. But we haven't quite documented that. So how do I think about this technology? Well, I want to leverage the advantages, speed, quality, but I want to mitigate any potential harm. So what I tend to do is I'm quite conservative. So I will do traditional T2 and diffusion images that are PI-RADS compliant. But I will leverage the DLR for the ultra high B value because I'm interested in a better quality ultra high B value, because that's where I suffer because I have a 1.5T system. So you can see on the bottom right, I've got some time savings, but I've actually got an improvement in quality of the ultra high B value. So that's how I think about it. So my protocol is actually longer than it used to be because I'm trying to, but in total, it's about the same, but I'm trying to be a bit more conservative. So currently I get T2's traditional and DLR. And then in the coronal and sagittal planes, I just go for DLR because there I'm interested in capsule, in sharpness, in staging, and lymph nodes. So I just take advantage of the time savings. Traditional DWI, then I use the DLR for the ultra high B value because I got a higher quality, right? For the DCE, we know that those ultra thin slices, they suffer particularly in big fat man, right? So there you want to improve quality because I'm not really interested in speed, right? I know that I have to meet a 15-second threshold, so I just want to improve the quality of the DCE. And sometimes we will use space sequences for biopsy procedures, in which case a DLR is obviously helpful. So the take-home points are that these DLR sequences can potentially transform workflow efficiency and comfort, right? I haven't said anything about diagnosis, right? The potential is in workflow and patient comfort, okay, because we can see improvements in quality. It may enhance the diagnostic workup of patients in terms of biopsy decisions. We don't know that for sure, but it certainly doesn't seem to be worse in clinical practice. And there's no doubt that we will need this technology as we go into screening procedures, because then we're going to have to do 6 patients an hour, right? So we are going to have to do scans every 10 minutes. Clearly, we need to stay involved with this technology in terms of a very critical evaluation, and we need to be very responsible about the implementation. Don't let your managers drive this agenda, because this is what I see. You know, they ramp it up and say you can do patients much, much faster. And then you actually end up with worse images, and that may lose diagnostic impact. Thank you very much.